Thank you, Mr. Chairman, sir. I'd like to thank John and George for this kind invitation to this unique symposium. Abdominal pain is one of the most common human experience. In fact, it's the most frequent reasons why patients consult a gastroenterologist or an internist, and it's the most common cause of coming to an emergency room. So this is an extremely common symptom. And before I actually go into how we approach patients with abdominal pain, I'll start with this very famous painting of 1887. This is probably the most famous medical painting. And this shows an English country doctor looking at a child who had abdominal pain, trying to diagnose what is the cause. You can see his intense looks. At that time, there were no CT scans or endoscopies for diagnosis. Just by listening to the parents and, of course, observing the child very intensely, he was almost right all the time. And even today, after 150 years, the diagnosis of abdominal pain is almost always made by clinical observations, inspection, palpation, and so on. And only about 20% of the patients would really require some sort of investigations to confirm the diagnosis. This was a cover in the Time magazine, which actually why pain hurts. In fact, for very long, we didn't understand the pathophysiology of this pain. And recent years, I think there's a lot of contribution from the neurobiologists who have told us why pain occurs and how it's transmitted and so on. And for abdominal pain, we have now clearly marked out the pathways that there are two types of pain that can occur coming from the abdomen. The first type of pain comes from the viscera. It's carried by these very thin nerve fibers. It's very diffuse, it's cramping, it's purely localized, and almost always this pain is in the central part of the abdomen. So whenever the abdominal viscera are involved, it's always central part. The second type of pain, the somatic pain, is carried by thicker fibers. It's very sharp, sudden, and it's well localized. And this type of pain comes from the parietis, from the peritoneal cavity, from the peritoneum, from the parietis, and so on. And this pain is localized to where the cause of the pain is. So this is an interesting phenomenon to understand before we go to the abdominal pain, because if you actually look at what happens in patients with abdominal pain, if they have pain in these organs, it's always in the center part initially. If they have pain, for example, in the small bowel or in this ileocecal region, the pain is periumbilical. And in the lower organs, pelvis, the pain is lower down. So you can localize the pain. The patient often, when he comes with pain regarding these organs, comes with a very diffuse type of pain, but approximately in these areas, and it's not very well localized. In general, when you see a patient with abdominal pain, there are three categories of patients one should think of. An acute pain, usually these patients come within 24 to 48 hours, but almost always before 1 week. So acute pain is defined as pain presenting before 1 week, usually few hours after the onset. If it comes in a recurrent fashion, of course, we call it recurrent pain. But the third category of pain, which is more difficult in clinical practice, is the chronic patients, chronic abdominal pain patients, which is defined as pain lasting for more than 6 months. Some people say 2, but 6 months usually. So these are the three categories of pain that we see in clinical practice. So let's analyze this. So if you get a patient with abdominal pain, acute, recurrent, chronic, how should you approach this patient? So let me start first with the case history. This was an 82-year-old female patient who came to us with a sudden onset of abdominal pain. There was blood in the stools. She had severe pain which peaked by about 3 hours' time, and she had nausea. She was slightly hypotensive. Her pain initially was in the umbilical area, supraumbilical area, but shifted to the left hypochondrium. On clinical examination, there was tachycardia. There was atrial fibrillation, and this patient was on anticoagulants. And on examination, the only positive sign was a rebound tenderness. Now, this is a very classic picture, and the diagnosis, I'm sure you must have already thought of, is an acute mesenteric infarction. In fact, this patient was operated on, and we found that she had an infarction of the left colon because of acute mesenteric ischemia. There was a thrombus in the atrium, which got dislodged, produced an obstruction, and produced this infarction. So the features are very classical of an acute mesenteric infarction. So clinical diagnosis can be made. Now this is a very busy slide and I don't want you to go through all this, but when you're diagnosing abdominal pain, the important things are what you should look at: onset, location, character, descriptor, and radiation. For example, I'll just tell you one example, and that is a patient coming with acute appendicitis. The onset is gradual. It's initially in the periumbilical region, but then radiates to the right lower quadrant. It's initially diffuse because it's visceral, but when the inflammation goes to the peritoneal cavity, it becomes localized to that site, and there's no radiation. So this is the classic description. For each of these abdominal pain, you have a different description, which can be very classical. Like the mesenteric ischemia, I told you, sudden onset, periumbilical, and then gets to the diffuse initially. So each of these have different things. So what you must look at in these patients is the chronology of how this pain occurs. And this is very important. When we see a patient with acute abdominal pain, what we look at is the chronology of events. Now, first of all, in some patients in whom the pain comes slowly, peaks, and then stays like this. This is classic example of appendicitis, pancreatitis, or acute mesenteric ischemia. So pain comes in 3 to 4 hours, it peaks and stays at that level. The second category of the patients are those who the pain is colicky, crampy, comes down, goes up, comes down. This is classic of biliary colic and intestinal colic. The third category of patients are those in whom pain is initially crampy but becomes continuous, and two classic examples of cholecystitis and renal colic. So you get severe pain, comes down, comes again, and then becomes constant. And finally, you have a group of patients in whom the pain is catastrophic. It comes in few minutes, less than an hour usually, becomes very severe, and this is examples of aortic dissection or a hollow viscous perforation. Pain can be very sudden. Just within a few hours' time, you get this pain. So these are the different. So when you look at the chronology of how this pain presents, very often you can come to a diagnosis just based on asking a patient's history. There are also certain very typical patterns of acute abdominal pain which gives you the diagnosis at bedside. You don't require any investigations. And classic example of a renal colic starting in the left loin coming down, appendicitis starting in the periumbilical region coming to the right iliac fossa, biliary colic radiating back, or pancreatic pain going back. So all these are classical descriptions, and many of the patients who come with these illnesses have this pattern of presentation. So if you look at the chronology and this typical pattern, very often just by the history you come to a diagnosis of what potentially is the cause of pain. There are also certain obvious visual markers which tell you what is the cause of pain. And this is, for example, if you have a patient with abdominal pain but has these purpuric spots on the peripheries, this is of course hinoxylon purpura. There is another category of pain. You have patients coming with abdominal pain, and then you have this very typical linear type of bullous lesions, herpes zoster. Sometimes pain comes before this bullous lesion comes, and after 1 or 2 days the diagnosis is obvious. You don't have to investigate these patients because the diagnosis is very obvious. And of course the classic Cullen's sign and Gray Turners in patients with acute pancreatitis, you sometimes see this very classically, and then the diagnosis is made. So visual inspection helps sometimes when these are there. But if you actually look at classic textbooks of medicine, they'll tell you that if you have a patient with acute abdominal pain, you have to inspect, palpate, but all this I don't think is right. All you have to do in these patients is not only the history, but inspection and palpation. By this time, the diagnosis is often made. Very little is required here. Most of these patients, you make a diagnosis just based on history, on inspection, and palpating these patients. And palpation, of course, the general rules that you start from the location away from the site of pain. Whenever a patient says, for example, pain is in the right hypochondrium, you start from the left hypochondrium. Because if you start from the site of pain, then the patient goes into guarding, so it's difficult to examine further. So this is a simple rule. So let's start with a patient who comes with acute abdominal pain and follow what we're supposed to do. So the first category of patients who come with severe pain, I don't know whether it's visible in the back there, but of course we have to, patient is hemodynamically unstable, they have to be resuscitated. Urgent surgical consultation is sought, and many of these patients have either perforated viscous or severe pancreatitis, or sometimes a ruptured aortic aneurysm. So these patients require immediate attention in the emergency and have to be treated immediately. Now, once this is over, if this is not the case, the second category of patients who come with right lower abdominal pain, which is gradual in onset and then gets localized. There's sometimes rebound tenderness. Very often it's an appendicular pain. We have an appendix protocol CT now. If on CT scan the appendix is more than 6 millimeters, the diameter, thickness of the wall, then you say it's an appendicitis. So you do a CT protocol on appendicitis, and then of course you diagnose this. In female patients, of course we consider other causes, pelvic causes for this pain. Now, the second category of patients are those who have same type of pain, but it's in the right upper quadrant. It's a cramping type of pain. And in these patients, the policy is to do an ultrasound scan, not CT scan, first ultrasound scan. And then you have your diagnosis of cholelithiasis or coli or stones in the bile duct and so on. So this is, now we come to the next category of patients. If these patients have increasing nausea, obstipation, constipation and so on, of course you are dealing with a small bowel obstruction, and here very often a plain X-ray abdomen gives the diagnosis. You don't have to do anything further. And coming to the last category of patients who have sudden onset of diffuse pain with tenderness and peritonitis, of course in these patients again sometimes mesenteric ischemia like I showed you, or acute pancreatitis has to be diagnosed. So based upon the pattern of presentation, clinical examination and very few investigations will often give us the cause of pain. Surprisingly, if you look at many hospital emergency services, you will find that 35% of abdominal pain patients don't have an obvious cause. There are no diagnosis in spite of coming with acute abdominal pain to the emergency. And in this category of patients, it's very important to think of metabolic causes for abdominal pain. There can be acute intermittent porphyria, diabetes, ketosis, lead poisoning. In all of these cases, the diagnosis can be very easily made by just doing the biochemical parameters. So it's important to remember these conditions. Now coming to the second category of patients, these are patients who come with recurrent abdominal pain, acute going to recurrent. And this is an example of a 42-year-old male patient who came to us with pain lasting for 1 or 2 days, then disappearing, then coming back again. He used to consume alcohol. The pain was radiating to the back, increasing after food. Of course, it was emaciated. There was no tenderness, no bruit, and the diagnosis is quite obvious in this patient that you're dealing with chronic pancreatitis. So this was a recurrent pain that he was coming with. There are certain very important common causes that patients with recurrent pain come to us: chronic pancreatitis, chronic mesenteric ischemia, recurrent diverticulosis. So these are common in clinical practice. But one of the things we look in these patients who come with recurrent abdominal pain is what aggravates this pain and what actually alleviates this pain. And for example, certain pains like typically mesenteric ischemia, pancreatic pain or gastric ulcer increase after food, half an hour to 1 hour after food. Certain pains like duodenal ulcer pain decreases dramatically after food. So these factors would also be important when considering the pain. What is again important to remember is patients with recurrent abdominal pain ultimately become a continuous pain. So we actually categorize them into type A when it's recurrent, type B when it becomes continuous. So if you look at the patients who's coming with pain, after a certain period of time, the recurrent abdominal pain patient after 6 months becomes a chronic continuous pain. So we come to the last category of patients, and this is the patient with chronic abdominal pain. Again, 36-year-old male patient who used to do heavy exercises in the gym came to us with severe abdominal pain. There was right upper abdominal pain. There's no relief with antispasmodics. Clinical signs were all negative, and the only positive sign was the Carnett sign. Now, Carnett sign is not often recognized that clinically most people don't do it, but a very important sign which gives the diagnosis. And this sign was positive in the patient and gave us the diagnosis. Now, what's Carnett sign? This patient, of course, has a myofacial pain, not intra-abdominal, but in the muscle layer itself. This is the typical Carnett sign. You ask the patient to raise the legs and press your hand on the abdomen. If the pain increases, it is the pain coming from the parietis, abdominal wall or the parietal peritoneum. But if the pain decreases, then the pain is coming from intra-abdominal organs like the gallbladder, appendix and so on. This is the specificity, sensitivity of the sign is very high. It's a very simple thing which is not often done in practice, but can be done very easily. And for example, in our patient, after a heavy exercise, had a small tear in the rectus muscle. And this caused the pain. Unfortunately, he got CT scans, ultrasounds, everything else done for this abdominal pain, thinking something in the abdomen. But this simple Carnett sign test gave us the diagnosis because there was tenderness. And then when we went carefully and looked at the CT, we found, in fact, he had a small tear in the rectus muscle which was causing this pain. One of the problems in patients with chronic abdominal pain is to distinguish organic pain from functional pain, and this is the most common problem in clinical practice. There are certain parameters to suggest organic or functional pain. If, for example, the pain is very acute and persistent, more organic. In functional, it's never very acute. It localizes in various locations in a functional pain, and the pain in organic is away from the umbilicus, and always the functional pain, most often when patient comes with functional pain, they'll point to around the umbilicus. They'll say pain is somewhere in the center part of the abdomen. And of course, there are other associated symptoms which point towards organic versus a functional pain. But it's important because, in fact, the Rome 3 criteria, with Rome criteria given for functional bowel disease is given a certain importance to functional abdominal pain syndrome, because this is very common in clinical practice. These two are very important, that functional abdominal pain is almost continuous, and many patients tell us they have pain throughout the day, sometimes throughout the night. So continuous abdominal pain without organic symptoms is very often functional pain, and they don't have any associated physiological. For example, occasionally some patients say that pain comes after food or after defecation and so on, but usually there's no relationship. These are the two important parameters that lead us to a possible diagnosis of functional pain. So therefore, when you're looking at patients coming with abdominal pain, acute, chronic or intermittent, it's often important to look at these various parameters to come to a diagnosis. For example, what is the onset and timing of pain, associated symptoms, intensity, duration, location and radiation, and most important, the chronology. I told you the four chronologies we look at. One of these four chronologies can fit into all the pains, and very, very often the character, precipitating events. So looking at these parameters clinically, in about 90% of the patients, one can often come to a diagnosis of what is the cause of pain. Very few investigations are required, like an ultrasound or sometimes a CT scan, to confirm your diagnosis so that these patients can be effectively treated. So, Mr. Chairman, sir, ladies and gentlemen, I think abdominal pain or even the abdomen has always been thought to be like a Pandora's box. But I think with a good clinical history, few investigations, we can often open this Pandora's box very accurately, and in majority of the patients, an accurate diagnosis is often the pathway to right treatment. Thank you for your attention.